There are a lot of complications that you can have with the pouch, but what I don't want you to do is taking away from this talk is that pouches are all bad. That's not the reality. The reality is the vast majority are actually very good, and people have a very good outcome. What happens is the few people who haven't had such a good outcome are the people that are often hurt, and that often get the press. And when they get that, it gets exploded and put out of context. So it's very important to remember there are things that can go wrong with a pouch, but there are many people out there who have well-functioning pouches. So normal pouch function is very variable. It tends to evolve over time. In the early phase, you have quite a lot of frequency and urgency. Can't tell the difference between flatus and stool, and that may persist for some people, and you get seepage and sometimes even incontinence. So the early phase is probably the most miserable part of recovering from a pouch, and it takes time for then adjustment to occur, adaptation to occur, for you to recognize what foods are going to make it worse and what are not, and generally you mold into something that's more stable, which is medium to long term. Bowels open 5 to 7 times a day. Most people find that they have to wake up at night to go, and almost 1 in 5 will have some urgency. Very long term, generally in the literature is reported that the bowel functional outcome does deteriorate. Now it's probably multimodal. It's partly to do with the pouch, partly to do with how your pelvic floor muscles work, and we do know that everybody's functional outcome gets worse with time.
Sorry to interrupt. Would this presentation apply equally to J and S's and K pouches, or is this more? This
is more for J's. K pouches have their own specific set of complications, and I haven't covered them in this. Yeah. So, as we saw in the earlier diagram, this is a very technical picture of what a pouch looks like and all the different elements of a pouch. So there's a bit of bowel here that connects to all the other bowel that's sitting in your tummy. That bowel then comes back, like I said, folds back on itself. So this bit is called the pre-pouch ileum, so it's the bit of bowel that's coming before the pouch is made. Then there's the pouch, and then as it comes back, this is called the post-pouch sort of ileum. It then attaches onto your back passage, which this bit here is your anal canal, and then there's a little cuff of tissue here between where the join is and where these little knobbly bits are. That's called the rectal cuff. So the reason why this is important is all bits of this can cause problems. So if you have problems with the bowel above the pouch, you can get adhesions, you can get a sort of a delayed entering of the bowel content into the pouch. SIBO is something called small bowel bacterial overgrowth. So it's a specific condition where basically this area, you develop lots of bacteria in it, and they overgrow, and then they change the way in which your microbes and your gut function, so you start going to the toilet quite a lot. And Crohn's disease. Now everybody badges Crohn's disease as a reason for a problem with the pouch, but actually most people don't have Crohn's disease. We just call it that because of the way in which they're presenting. If you actually looked at all the people that had their pouches removed, only 20% of the people that we thought had Crohn's actually had Crohn's. So often you're labelled as having Crohn's when you don't. What can go wrong inside the pouch? You can get inflammation in the pouch, and I'll talk a bit about that in the next few slides. You can get inadequate volume, so that's where the pouch is quite small or it's shrunk over time, so it doesn't hold as much stool in it, so you're going to the toilet a lot more, and problems with how it's moving, which, like I say, can happen to you even if you didn't have a pouch. We do know that people's bowels don't function in the same way as they go through life.
Sorry. Colics can occur in a pouch?
Yes.
Are there anything to worry about?
So it depends on how many and in what context. So if you have FAP or HNPCC and you develop polyps in your pouch, then we would be concerned. But if you don't and you had UC, most of the time they're inflammatory and they're benign. Occasionally they have dysplasia in them, and then it's a very difficult conversation, which I have had with a few patients, where they have a very good functioning pouch and they have 1 or 2 polyps, one of which has come back showing abnormal cells that almost like cancer. And then you have the discussion about whether you can actually remove that and just keep an eye on it, or whether you just remove the whole pouch. So that can be difficult, but the vast majority are benign. And then problems below it, again, we heard a little bit about it earlier, where you can get narrowing of where that join is between the pouch and the back passage. You can get a fistula developing. Your muscles around the back passage, as I say, get weaker over time, so you can't hold on to the stool as you did before. And you can get a little bit of inflammation in that area, which I call the cuff, which is called cuffitis, which behaves a little bit like colitis. It's the same sort of phenomenon, and that can disrupt how your pouch functions. And then outside of all of this, you can get infections like an abscess or fluid collection away from the pouch that just upsets the rest of how your bowel's functioning, and your bowel doesn't function as it should. This is classification of all of those things based on cause. So you can have something go wrong with this, how we've done the operation, and that can cause a problem. You can have inflammatory conditions, so the area becomes inflamed. You can have a mechanical problem, so to do with the technical way in which the pouch is sitting, or how the bowel's sitting around the pouch. As we've just mentioned, you can get cancer and dysplasia in the pouch. That is very rare. It's not very common at all. There's literally a handful of cases reported for true cancer in the pouch. You can get functional problems, and then other things that can affect you globally can affect the pouch as well, like thyroid disease and celiac disease. So 1 in 10 pouches fail at 10 years is what's quoted in most places. And what we mean by fail is you've actually had the pouch removed, or you've had it defunctioned and you've got a stoma. That's the definition of how they define failure in this context. What it doesn't allude to is that there are some patients who have a pouch who don't have a very good functional outcome, but carry on with the pouch and have the quality of life that they want to have. So those patients are not included in that 1 in 10 rate. And the most common reason that you end up losing a pouch is if you develop an infection, which is usually around the area where we've done that join. And most of the time it's to do with the technical surgical way in which that joint has been made, or how it's healed. So if you have an infection at that area where there's a joint, it's very difficult to actually fix it so that your pouch then becomes like a normal pouch. Poor function, so 1 in 5 patients, we will not know why you've got poor function, and we then can't treat the poor function, and that then means that you come forward for either an ileostomy or to have the pouch removed. And chronic pouchitis, where the pouch becomes inflamed on a recurrent basis, again, about 20 to 30% of patients, we won't be able to treat those medically, and then you lose the pouch because there aren't any treatment options, or treatment options don't work. The other causes, which are much, much rarer, are if you develop a fistula, mechanical problems that we can't solve with an operation, or if you rarely have Crohn's disease in the pouch. I work with a really nice researcher, and she's had a pouch, and she basically said that she was told she had Crohn's, she's been on biologics, and she's had a pouch for 3 or 4 years now with good functional outcome. And, you can have it. So I think the whole conversation about this is about what's important to you. What somebody else might find is important is not going to be relevant to you. So if it works for you, then you should stick with it. So, assessment of pouch dysfunction. So this is what happens when somebody comes along and says, my pouch is not working like it was, I'm going to the toilet lots, I'm waking up at night, I'm generally not feeling very well, I feel like my colitis has come back. And that's often the feeling that's described. And the key thing to find out is, do you have something called idiopathic pouchitis, where there's no cause, none of the things that I put up before apply to you? That's called idiopathic pouchitis. We don't know why you've got it. Other sources of inflammation, like the infection, or completely something not related to pouchitis. It's to do with all the other things, like I said, mechanical things or functional things. And how do you work out what's going on? So it's to do with how long you've had the problem. So some people's pouches won't work from day one. And like I said, the early period, you don't know whether that's just because things are settling or whether there's actually a problem. And then if that continues over the longer period of time, then it's likely that the cause for the pouch not working is to do with how the operation was done, and it's more likely to be a leak or like a problem around that joint, or a problem in which there's a mechanical issue. If you've recently deteriorated, so you've had a pouch for 3 or 4 years, you've been really well, and then suddenly it goes wrong, then there's more likely to be a different cause for it. It's not likely that it's to do with how around the joint or infection or anything like that. It's something else. So we've got to change what we look for depending on how long you've had the problem for. Like I said, you have to review the bowel that was removed the first time round. Was it UC? Was it Crohn's? Were we not sure? Were there problems immediately after the surgery? Because if there were problems immediately after the surgery, then again, the way in which you look at it changes. And then you go through all the sort of usual steps of examining you, looking inside the pouch, and looking for other reasons for the pouch not working. So it's a bit like Jack in the Box. You have to look all around the box to find a reason for why the pouch is not working, and there's a whole host of tests and things that you can undergo for us to work out exactly what the cause is. And these are some of the causes that are not idiopathic. These are some of the things that we can actively do things about, or we can treat. So these are the things that we're looking for when we're doing that detailed assessment. So common problems are acute pouchitis, so the pouch just became inflamed. We would look for all the different reasons why you could have that, but if we don't find any of those with all the tests, then we call it idiopathic pouchitis. Irrespective of what the cause is, you treat it with antibiotics. Most people will find that it responds to antibiotics and it goes away. In a small proportion of patients, it doesn't, and it happens again, or it lasts for longer. The long-term complication of it is a narrowing where that joint is. Again, you can easily fix that, put you to sleep, dilate it, and then give you a dilator thereafter if you need it. Sometimes people come back every 6 months to have it dilated, and that keeps the pouch working and keeps them going. Caphitis, like I say, is that area between the pouch and the back passage where there is a little bit of the old rectum left behind. That can be treated with topical steroids or misalazine enemas, a bit like if you had just inflammation in the back passage, you would treat it, and it responds quite well to that. When you look inside the pouch, if there is inflammation, you want to know where it's inflamed, how the pouch is moving, whether we think that there's any other reason why the pouch is inflamed. And there's some of the common things here are ischemia, so there's not good blood supply to the pouch, infections, or something called collagenous pouchitis. If there's ischemia to the pouch, i.e. the blood supply to the pouch isn't what you want it to be, then there's not much we can do about it. Then we will treat it with antibiotics. But the other things on that, the infection we can treat with different set of antibiotics, and collagenous pouchitis you can treat with steroids. Assess the pouch, the bowel above it, and then outside the pouch, this is the dye test that you would have, where they put dye up the bottom and they look and see whether the dye is leaking out anywhere or whether there's a communication and a tract somewhere, and that tells us if there's inflammation or infection present. And then this is where it narrows down and we can dilate it. Just wanted to mention pouch vaginal fistula. So you often get patients who've had pouches for 10, 15 years, and then they develop a fistula to the vagina, okay? And that is quite a difficult condition to treat, and most of the time we end up having to do another operation to either fix it or defunction the pouch. So that's one of the specific sort of complications for women that tends to result in pouch failure. And then all the other things are more technical. Above the pouch, like I said, you can get adhesions and scarring. That's often a cause for the pouch not working like it should. And like I say, it's not simple, and that's often the difficulty with this. It's hard to work out whether the pouch is not functioning because there's a cause for it, or whether it's just one of those things and we're not going to find a cause. But there are treatments that we can give. So antibiotics is one. I'll leave that one out. And then this is, and then the other treatments are biologics. So this is pouchitis in the pouch. It's non-specific inflammation. So this is when you've ruled out all the other things that I've listed so far, and you can't find a cause. We call it idiopathic pouchitis. And like I say, it feels very much like colitis. You're going to the toilet lots of times, you're getting cramps, you've got fever, weight loss, all of the sort of symptoms of colitis are coming back. Who gets it? So these are the people who get it. Somebody who uses steroids all the time, regular steroid use. If you've got these P-ankle antibodies, which are specific for ankylosing spondylitis, extensive UC PSC, so that's primary sclerosing cholangitis, which is a liver condition which is associated with ulcerative colitis. If you have that condition, then you're more likely to have pouchitis, and that's often the reason why we say we won't do a pouch if you've got that condition. And people who don't smoke, interestingly. It is quite prevalent, so 30 to 50% at 10 years, but like I say, for quite a lot of people, it's just a one-off. It's not a continuous thing. Lots of different theories of why you might get it. How it's diagnosed is basically what I've just said, similar sort of criteria that we use based on how often you're going and whether you've got general signs of being unwell. So acute usually resolves in 2 to 4 weeks. Continuous relapsing is when it happens on a recurrent basis, but as you can see on that picture, only 5 to 10% of patients will develop chronic pouchitis, which is the problem. Acute pouchitis is treatable and it goes away. If it keeps happening, you can either keep giving antibiotics and keep you on a longer course of antibiotics, and if the antibiotics stop working, we can give you biologics. So this was a really good trial where they looked at I'll go back to this one, vedolizumab. So if you give vedolizumab, it basically led to a resolution of chronic pouchitis in patients. And it's the only trial that's ever been done for this category of patient. So there are treatments out there, and with the newer biologics coming in, there are things that we can give. And this is just basically a sort of classification of how we can diagnose you with what categories of pouchitis and what we can do about it. So 30% patients, we don't know why you get it. The main thing is to exclude all the secondary things that I've explained, and the mainstay of this is what impact it has on you. Okay, so if you can carry on, and I have patients who turn up to the clinic and they say, I'm going 10 times a day and I'm going 3 times at night, but it's fine, I'm carrying on, then it's okay, we're going to carry on. But if somebody else is going that many times, they might not be able to cope with that, and then it's tailoring the treatment to that person. And that's it. And now I can take questions.
Nationally across the UK a preference towards ileostomies or pouches at particular hospitals. So do certain hospitals sort of steer patients towards an ileostomy instead of a pouch, or the other way around?
Very good question. I sit on the National IBD subcommittee, and we're basically setting up a pouch working group as part of it. And one of the areas that I've said that we should explore is sort of the whole counselling process of when you come to a decision about whether you're going to have one or not. Generally, what I've seen over the last few years is people coming to the clinic and saying they don't want a pouch, even if they're in their 20s. You know, they're sat there saying, I'm happy with this, I don't want to upset anything, I want to keep my life as it is, and just remove the rectal stump. And I find it really hard because there are plenty of other patients who've come and had pouches and have had a good outcome. So what I tend to do is I tend to leave the onus on the patient. If you come to the clinic and say you want a pouch, then I'll do a pouch. If you come to the clinic and say I would just want my rectum out, then I'll do that. And if you're unsure, I'll give you a reading list and I'll bring you back and get you to talk to another patient. So I think that's how I do it. But we are accredited for pouches, so there's a whole accreditation process that's going on. The centres that are not accredited, some of the surgeons are shying away from pouches, if I'm being honest, because they do come with their own unique set of complications and problems. And if you don't feel confident managing those, then you're not going to be confident offering a pouch. So there is general reluctance to offer pouches some places, and the newer generation of surgeons coming through, we are now looking at how we train those surgeons to be able to offer pouches safely, because they are going to be looking after people when they're coming 20, 30 years down the line having had a pouch, so they still need the skill set to be able to deal with it.
Just to follow up to that, if there isn't a specialism within the hospital, are they more likely to end up with complications?
Yes. So people ask about that as well. There is some data. It's not particularly UK-centric. It's mainly American, which basically looks at minimum numbers of pouches that you need to perform to be safe. And we generally know that if you have your surgery in a high-volume centre, you have less complications. Whether that's a statistical phenomenon or that's reality is more difficult to prove, but generally that is what is described.
Can I just ask, I know I'm familiar with the whole accreditation pouch units. So say your commentary on it, which is Worcester, are we all the way there at getting, like psychologist, dietitian, or is that going to be
That's going to be a gradual process. So on the accreditation, there were certain things, one of which was psychologist and dietitian, specialist pouch nurse, all of those things. People were not accredited if they had all of those things, because from the preliminary set of registrations that came through, I think less than 20% of people had psychologists available to them. We have a psychologist through the intestinal failure service, which we sort of ring fence if we need it for pouch patients. But there aren't many. So it's recognising that there are lots of pouch pathway care that we can sort of improve. So it's more what we're going to aspire to rather than what's on the reality on the ground for the future.
Can I ask how big an operation it is to have the pouch removed totally, and what's the success rate and any complications?
So again, depends on the context of that, why you're having it removed. So if you're having it removed because you've developed fistulas or a chronic infection, then it can be a big operation. The main difficulty then is actually when we sew up the bottom, whether that bottom will heal or not, because it's sat in an area which has been infected for a long time, versus if you're having it removed because it's twisted or you've got scarring or some other reason. So how big an operation it is will depend on why you're having it removed firstly. Secondly, how it's being done. So we're starting to now remove them keyhole. So if you've had a keyhole pouch made, then we can potentially remove it keyhole as well. But we have actually had, I've had only a handful of cases, but we've done a handful of cases where if you've had an open pouch, we've removed it keyhole. So it is possible to do it. It is technically a very difficult operation to do because everything tends to be quite scarred down there. And so the complication rates are higher. They're no different to the ones that you would have been told about when they made the pouch. The main thing to worry about as a man is your pelvic nerves and sexual function. As a woman, if you're in that age bracket, your fertility. But aside from that, there aren't any dramatic complications that I would be concerned about. Yeah.
I can't remember how to pronounce it, but when that method that Dave was used, he said,
Oh yes, ileorectal.
Is that something that we might go down that route?
Yes, so there aren't many places. I don't do them, if I'm being honest, because I don't have much experience of doing them. So if I have a patient who wants to have it done, I will refer it down to the Queen Elizabeth, and I know Professor Pinkney does them. So there are isolated IBD surgeons across the UK who will do it, and I think the awareness about offering it is becoming more prevalent. So I offered it to a patient who was wanting to retain his rectum stump and specifically said, I want to go and have this done. So we referred him for it. So I think it is not as prevalent as an ileoanal pouch. And like I say, the default will always be an ileostomy. So all surgeons can remove the rectal stump. Some surgeons will be able to do a pouch. Very few surgeons will do an ileorectal anastomosis. So that's the sort of way to think about it. It doesn't mean that you can't go to your surgeon and say, can you send me somewhere where they do this? That's perfectly reasonable.
Can you have an ileorectal anastomosis if you've had a J pouch defunction removed?
No, because you've lost the rectal stump. So I'll take you because I keep looking at you.
Yeah, no, it's fine, isn't it? Hey, with the sort of advancements in modern medication, it's looking at that quantifiable, quantifiable reduction in the amount of pouch surgery being done, and if so, what's longer-term implications of that?
In terms of what, the fewer pouches being done? Yeah, I can tell you that there are fewer pouches being done. We don't have the data to support it because we haven't collected that data. We're in the process of actually looking at it across the UK. But generally speaking, the anecdotal evidence from talking to colleagues and IBD surgeons is they're not doing as many pouches as they used to. I mean, I've seen it in my own practice. Like I say, most patients now come and say, I want an ileostomy, and you're actually having the conversation about, are you sure you want an ileostomy? Do you want a pouch? Whereas previously people would come and say, I want a pouch.
A longer term, that's sort of effectively.
So longer term, it's going to, exactly, and that is a real concern, because I think it is an operation that should still be readily available to people if they want it. So we shouldn't be, disadvantaging you because you're in a pocket area where the surgeons don't offer it routinely. And that's something that we as colorectal surgeons need to look at.
And is that the reason why the numbers are going down, or you think it's because younger people are looking at those who are advocating for stomas on social media, and it's not trendy, but it's more acceptable, I suppose?
Yes.
Yeah.
I think that's got a large part to play.
Pouch to the back of their mind because
Yes.
they're thinking having a stoma is okay.
Yeah, which is good because that's where we want stomas to be, but equally it means that they're not often open to the idea of a pouch because, and also, from a patient perspective, I can only assume, but if you've had horrendous colitis and then you get an ileostomy, you get your life on track, and then somebody comes and gives you this presentation, tells you there's loads of problems that could happen, the vast majority of people are going to run away from that and say, I really don't mind the stoma anymore, and I'll get rid of the rectum and I'll stay with the stoma, because that is the default easier option in a way, because you know what that's going to be like. You don't know what a pouch is going to be like, and so it's the fear and the uncertainty of knowing what that's going to look like for you that often puts people off.
Do you think coming through like medical school and then when you do the specialities, do you think that if pouch surgery was available to them on the curriculum, that would kind of reinvent? Because if doctors aren't learning what a pouch is, does that kind of affect,
It does affect it, because I've said to colleagues who don't do pouches, I'll take patients with pouches, or who want to have a pouch, but I will only get a patient if the patient has decided to have a pouch. I will not get the patient who's unsure about having a pouch. And then if you don't do pouches, how well can you counsel a patient if you don't do that operation? And that's the problem. I think that, we've got to find a better process for the counselling that is informed. So at the moment, we're looking at that with the whole pouch sort of accreditation bit. We're trying to come together, looking at trying to standardise the information that's given so that everybody gets sent the same information, and then potentially make that referral process a little bit more easier. So it's not, quite often it's considered a failure if you have to refer a patient to somewhere else, and we've got to move away from that. I think it's not a failure, it's you're sending somebody to get care where they can deliver it in a different way and a better way than what you're delivering. And that surgeons have to be open to that, and that's the difficulty, I think, at the moment.